Hey guys, so I had a patient come in for a left shoulder discomfort, left shoulder and neck stiffness, but left shoulder discomfort with and weakness with exercising. Patient's right hand dominant. Onset, the patient's really not sure, but they think the patient thinks it's related to sleeping on the shoulder for an extended period. Uh, Patient reports improvement since the onset, but struggles with lack of strength. That's still an issue. Activities that are impacted: work, prolonged computer sitting contributes to increased stiffness in the left side neck and shoulder. Exercise, so running tends to stiffen the shoulder afterwards. And while patient recently transitioned to gym workouts, I noticed left shoulder is weaker, particularly during bench press and lateral raises. Past medical history, they've actually had right shoulder issues, no medications. So quickly on observation here, you can see this patient, even just by lying there, you can see that there is a compression on that left side of the neck, which could contribute to nerve compression on this side. So that's something that you should always take into account when assessing patients. When it comes to objective findings, the range of motion was pretty much within normal limits, but there is noticeable cracking with internal rotation when we do bring that into internal rotation. So it could be like a tendon that's snapping. Strength, we've noticed that there's a significant left shoulder significant reduction in strength. I'll get back to the hip part. So there's a reduction in strength, and also what we notice is that there's compensating with the neck muscles in order to stabilize the left shoulder joint. Speeds test was positive, indicating there's potential biceps involvement, most likely compensating once again for the lack of stability in the shoulder joint. Trigger points: upper trapezius noticeable, trigger points subscapularis, rotator cuff, lat, teres minor. They were all quite weak, quite a bit of trigger points in there. So what I did for trigger points, obviously just hands-on therapy to those specific muscles. Did some shockwave on the rotator cuff, right at the anterior deltoid area as well. That was quite sensitive. So we did all of that, and then what I also did, just because one of the things that I've noticed is that the running part, so the shoulder tends to also stiffen up after the shoulder, neck tends to stiffen up after the running. So whenever I see that, I always try and assess and see what's going on in the lower extremity to see whether the lower extremity can have an impact on on the neck stiffness, because often what can happen is that if there is any issues with either the right or the left hip, there could be compensations. And what I did was I did a single leg stance test just to kind of get an idea. So overall, I mean, you can see it's really hard to find many compensations with this patient, because he is an experienced runner, so he's been doing that a lot, and as a result of that, the body, what it does, it fine tunes the compensations to make them less and less apparent. So you can see here on the left side, I really didn't really see much, maybe a little bit more of a lateral shift in there. Also, I mean, it could also contribute the fact that this right hip is a little bit more externally rotated compared to this picture. But I didn't really see much, and you can see the center mass is pretty good. Hips are pretty good. So seeing that, and now on the right side, what I'm tending to look for is I'm looking to see at this tibia. I'm looking to see how much rotation there is in the tibia, and I'm looking to see where that knee is facing. You can see here the knee is facing straight, whereas in here, that knee is a little bit more internally rotated, meaning facing, looking this way. So as a result of that, that gives me a little bit of an indication that this patient is rotating counterclockwise on his right hip. So that means he's not utilizing his glute muscles as much, but rather he's using his hip flexors a little bit more and biasing those areas, maybe because of the fact that he his glute stability is not there. What I'm also looking to see here, center mass, once again, pretty good. Does not lateral shift as much. What I do notice a little bit more, it's actually pretty even. You can see the contralateral QL is really not kicking in as much, although there is quite a bit of tone through the back. And also what I can see is based on the shoulder height, gives me a little bit of an indication that this patient, this right shoulder is potentially a little bit more forward leaning and also once again rotating to the front. So I feel like one of his compensation is that counterclockwise rotation. And also potentially what he's also using when he's running, he is using this contralateral upper trapezius to stabilize. And also what he's also potentially doing, he's looks like he's maybe leaning a little bit more to that right as he's standing on this right leg. So meaning he's leaning more to the right, the right shoulder is a little bit lower, and then as a result of that, this left side picks up a little bit more. So so then what I did after doing this observation, after that I looked at the right hip, and I did notice that the right hip stability, trying to engage the glute muscles, is a lot less than the left side. So as a result of that, that gives me an indication that the right hip could also have an impact. And then I also did a palpation of the right glute, and I noticed that there was definitely some glute, quite a few trigger points in there that could be causing issues as well. So the bottom line is, what we have to do is when looking at a patient like this, especially someone that comes in with this, that really doesn't know why the onsets occurred, what we need to do is we need to look at and see, in addition to the joint area that they're complaining of, what else could be causing that. But regardless of what happens, in conclusion, symptoms are in the left shoulder and the neck area. Therefore, first session, you must treat these areas so that the patient can see some improvement. They can be like, okay, well, this is working, rather than right away just trying to work on that right hip. What I did towards the end of the session was I said, hey, we'll look at the right hip next time, but we're going to focus on today we focused on the left upper extremity to see whether we can get some benefit. And then long term, what we want to do is set a goal to look at the right hip and see if we can improve some stability here as well.